Postural assessment checklists and worksheets. When performing basic postural assessments, trainers can use the checklist provided in Figure 7-20 to guide themselves through their observations and complete the worksheets provided in Figures 7-21 and 7-22 to mark any postural compensations they identify. In Figure 7-21, the postural assessment checklist, you will be looking for the following. In the frontal view, you will be looking for overall body symmetry, symmetrical alignment of the left and right hemispheres. In ankle position, you will observe for pronation and supination. In foot position, observe for inversion and eversion. At the knees, observe for rotation and height discrepancies. Hip adduction and shifting. Observe for shifting to a side as witnessed by the position of the pubis in relation to the plumb line. Observe for the alignment of the iliac crests. Observe for the alignment of the torso, the position of the umbilicus and sternum in relation to the plumb line. Observe for the alignment of the shoulders. Arm spacing. Observe the space to the sides of the torso. Hand position. Observe the position relative to the torso. Head position. Alignment of the ears, nose, eyes, and chin. In the posterior view, you will observe for overall body symmetry, symmetrical alignment of the left and right hemispheres, alignment of the spine, vertical alignment of the spinous processes. This may require forward bending. Alignment of the scapulae, inferior angle of the scapulae and presence of winged scapulae. Alignment of the shoulders, head, alignment of the ears. In the sagittal view, you will observe for overall body symmetry, symmetrical alignment of load-bearing joint landmarks with plumb line. Knees, flexion or extension. Pelvic alignment for tilting, the relationship of the ASIS to the PSIS, or the relationship of the anterior superior iliac spine to the posterior superior iliac spine. Spinal curves. Observe for thoracic kyphosis, lumbar lordosis, or flat back position. Shoulder position. Forward rounding or protraction of the scapulae. Head position. Neutral cervical curvature versus a forward position and level position above the clavicle. Figure 7-21 is a worksheet for identifying and documenting anterior or posterior deviations. Figure 7-22 is the worksheet for recording sagittal left side or right side deviations. Movement screens. Observing active movement is an effective method to determine the contribution that muscle imbalances and poor posture have on neural control, and also helps identify movement compensations. When compensations occur during movement, it is usually indicative of some form of altered neural action, commonly referred to as faulty neural control, which normally manifests due to muscle tightness or an imbalance between muscles acting at the joint. Key concept. Movement can essentially be broken down and described by 5 primary movements that people perform during many daily activities. Bending, raising, and lifting lowering movements, e.g. squatting, single leg movements, pushing movements in vertical and horizontal planes and the resultant movement, pulling movements in vertical and horizontal planes and the resultant movement, and rotational movements. ADL are essentially the integration of one or more of these primary movements. For example, the action of picking up a child and turning to place the child in a car seat involves a squatting movement, a rotational movement, a possible single leg movement if stepping is involved, a pushing movement, and finally a pulling movement to resist the effects of gravity as the child is lowered into the seat. Movement screens help trainers observe the ability and efficiency with which a client performs many ADL. The movement screens, however, must be skill and conditioning level appropriate and be specific to the client's needs. It is important to remember that almost any screen can evaluate functional capacity as long as it is relevant to the client's needs and challenges and provides useful feedback on movement efficiency. Screens generally challenge clients with no recognized pathologies to perform basic movements and evaluate their ability to demonstrate appropriate levels of stability and mobility throughout the entire kinetic chain, namely at the feet, knees, lumbopelvic hip complex, shoulders, and head. If the client experiences pain during a movement screen, the test should be stopped, and the client should be referred to his or her healthcare provider to have the painful area evaluated before performing that type of movement in a future exercise session. Bend and lift screen. The objective: to examine symmetrical lower extremity mobility and stability and upper extremity stability during a bend and lift movement. Equipment: 2 to 4 foot or 0.6 to 1.2 meter dowels or broomsticks. Briefly discuss the protocol so that the client understands what is required. Ask the client to stand with feet shoulder width apart with the arms hanging freely to the sides. Place the two dowels on the floor adjacent to the outside of each foot. Ask the client to perform a series of basic bend and lift movements, i.e. a squatting movement. To grasp the dowels and lift them off the floor, holding the lowered position for 1 to 2 seconds to allow the trainer to make some brief observations before returning to the starting position. The number of repetitions performed is determined by the number needed to make necessary evaluations. Ask the client to pretend the dowels are 25-pound weights. It is important to remember not to cue the client to use good technique, but instead observe his or her natural movement. Observations. Frontal view, figure 7-23. First repetition, observe the stability of the foot, i.e. evidence of pronation, supination, eversion, or inversion. Second repetition, observe the alignment of the knees over the second toe. Third repetition, observe the overall symmetry of the entire body over the base of support, i.e. evidence of a lateral shift or rotation. Sagittal view. First repetition, observe whether the heel remains in contact with the floor throughout the movement. Second repetition, determine whether the client exhibits glute or quadriceps dominance, i.e. does he or she initiate the downward phase by driving the knees forward or pushing the hips backward. Third repetition, observe whether the client achieves a parallel position between the tibia and the torso in the lowered position, sometimes referred to as the figure 4 position, while also observing whether he or she controls the descent to avoid resting the hamstrings against the calves. Fourth repetition, observe the degree of lordosis in the lumbar thoracic spine during the lowering movement and while the client is in the lowered position, i.e. flat to neutral or demonstrated increased lordosis, and watch for excessive thoracic extension in the lowered position. Fifth repetition, observe any changes in head position during the lowering phase. General interpretations. Identify origins of movement limitation or compensation and evaluate the impact on the entire kinetic chain. Table 7-9, bend and lift screen. In the anterior view of the bend and lift screen, focusing on the reference of the joint location of the feet, the compensation that you may view is a lack of foot stability. The ankle could collapse inward or the feet could turn outward. If you observe this compensation, the key suspected compensations of overactive or tight muscles are the soleus, lateral gastrocnemius, and the peroneals. Key suspected compensations of underactive or lengthened muscles are the medial gastrocnemius, the gracilis, sartorius, and the tibialis group. In the anterior view of the bend and lift screen, the joint reference or joint location that you may observe a compensation in is the knees. The compensation observed may be that the knees move inward. If you observe the compensation of the knees moving inward, The key suspected compensations of overactive or tight muscles are the hip adductors or adductors and the tensor fascia latae. The key suspected compensations of underactive or lengthened muscles are the gluteus medius and maximus. In the anterior view of the bend and lift screen, the joint location or joint reference to observe is the torso. A possible compensation that you observe in the torso during the bend and lift screen may be a lateral shift to a side. The key suspected compensations of overactive and tight muscles or underactive and lengthened muscles would be side dominance and muscle imbalance due to potential lack of stability in the lower extremity during joint loading. In the sagittal view of the bend and lift screen, a joint location for observation or joint reference is the feet. The compensation viewed in the sagittal plane is that the client is unable to keep the heels in contact with the floor. Key suspected compensations of overactive or tight muscles in this view at the feet would be tight plantar flexors. There are no underactive or lengthened muscles suspected in this compensation. In the sagittal view of the bend and lift screen, a joint location or joint reference during the movement is the hip and the knee. The compensation would be the initiation of the movement. Movement initiated at the knees may indicate quadriceps and hip flexor dominance, as well as insufficient activation of the gluteus group. In the sagittal view of the bend and lift screen, the joint location to observe is the tibia and torso relationship. Compensation that you would view or that you would observe in the bend and lift screen in the sagittal view would be that the client is unable to achieve a parallel between the tibia and the torso. Key suspected compensations of overactive or tight muscles and underactive or lengthened muscles would be poor mechanics, lack of dorsiflexion due to tight plantar flexors, which normally would allow the tibia to move forward. In the sagittal view of the bend and lift screen, if you notice that the knee contacts, if there's contact behind the knee and the hamstrings contact the back of the calves, the key suspected compensations of overactive or tight muscles and underactive or lengthened muscles would be that there is muscle weakness and poor mechanics, resulting in the inability to stabilize and control the lowering phase. In the sagittal plane of the bend and lift screen, a point of reference to observe or a joint reference or joint location is the lumbar and thoracic spine. If the thoracic spine is excessively arches or the lumbar spine is excessively arches, the key suspected overactive muscles or tight muscles would be the hip flexors, the back extensors, and the latissimus dorsi. The weakened or underactive lengthened muscles would be the core, rectus abdominis, gluteal group, and hamstrings. If the back rounds forward, the suspected tight muscles would be the latissimus dorsi, teres major, pectoralis major, and minor. The suspected underactive or lengthened muscles would be the upper back extensors. In the sagittal view of the bend and lift screen, one joint location to observe would be the head. If the head moves downward, the key suspected compensation is increased hip and trunk flexion. If the head moves upward, the key suspected compensation is compression and tightness in the cervical extensor region. Expand your knowledge. Movement patterns during a squat. The gluteals and core musculature play an important role in the squat movement during which individuals can exhibit lumbar dominance, quadriceps dominance, or glute dominance. Lumbar dominance implies a lack of core abdominal and gluteal muscle strength to counteract the force of the hip flexors and erector spinae as they pull the pelvis forward during a squat movement. In this scenario, the individual experiences excessive loads within the lumbar spine as it moves into extension during the squat. The muscles of the abdominal wall and gluteal complex do not contribute enough in this situation to spare the back and foster proper execution of the squat. Chronically tight hip flexors, such as those experienced by individuals who sit for prolonged periods throughout the day, may also contribute to this problem. Quadriceps dominance implies reliance on loading the quadriceps group during a squat movement. The first 10 to 15 degrees of the downward phase are initiated by driving the tibia forward, creating shearing forces across the knee as the femur slides over the tibia. In this lowered position, the gluteus maximus does not eccentrically load and cannot generate much force during the upward phase. Quadriceps dominant squatting transfers more pressure into the knees, placing greater loads on the anterior cruciate ligament, or ACL. Glute dominance implies reliance on eccentrically loading the gluteus maximus during a squat movement. The first 10 to 15 degrees of the downward phase are initiated by pushing the hips backward, creating a hip hinge. In the lowered position, this maximizes the eccentric loading on the gluteus maximus to generate significant force during the upward concentric phase. The glute dominant squat pattern is the preferred method of squatting, as it spares the lumbar spine and relieves undue stress on the knees. Glute dominance also helps activate hamstrings, which pull on the posterior surface of the tibia and help unload the ACL to protect it from potential injury. Expand your knowledge. Squats and lunges is never let the knees go past the toes an appropriate movement cue. While it is important to avoid excessive forward movement of the knee during squatting and lunging movements, it is a myth that exercisers should never let the knees go past the toes while doing a squat or lunge. This common movement cue originated from a 1978 Duke University study that found that keeping the lower leg as vertical as possible reduced shearing forces on the knees during a squat. In truth, leaning the trunk too far forward is more likely the cause of any injury. In 2003, researchers confirmed that the knee stress increased by 28% when the knees were allowed to move past the toes while performing a squat. However, hip stress increased nearly 1,000% when forward movement of the knee was restricted. In addition, in group exercise, the cue, "don't let your knees go over your toes," has long been an effective general rule when trying to teach an exercise to a room full of people with different skill levels, abilities, and goals. When a class has a large number of participants, it is difficult to help each individual participant with his or her specific range of motion, so providing this general cue is an effective way of erring on the side of caution for the group fitness instructor. The general pointer while performing a lunge is to try to keep the knees aligned over the second toe so that the knee is moving in the same direction as the ankle joint. However, in reality, clients often find the knee translating toward the toes or beyond in a squat or lunge movement, so there are other things that must be considered, specifically limb length. During lunge or squat movements, personal trainers should always emphasize beginning the movement by pushing the hips backward before lowering to the floor, an action referred to as hip hinging. This technique prevents premature forward movement of the knee by shifting the hips backwards. As the exerciser continues to lower his or her body downward, this creates a healthy hinge effect at the knee. But there comes a time where the knee or the tibia will begin to move forward in order to maintain balance, keeping the center of mass within the base of support. If an exerciser happens to have long limbs, then it is realistic to expect the knees to move forward over or beyond the toes. Any attempt to prevent this motion will result in either the client falling backward or bad squat or lunge technique that places increased loads on the lower back. As long as personal trainers teach the lunge squat movement correctly by first initiating the movement at the hips and avoid premature forward movement of the knees, then the fact that the knees are moving forward is quite safe.